Intravenous therapy, blood product transfusion. Blood products are transfused to restore and/or maintain fluid volume, to improve the oxygen carrying capacity of the blood, to replace deficient blood components, and also to assist with coagulation. Now, there are different criteria for transfusion. It used to be if we had a low hemoglobin, we automatically would begin transfusing some packed red blood cells. But it's not given automatically with low blood levels anymore. We look more at the symptoms. The symptoms to prompt a transfusion will include shortness of air, tachycardia, low blood pressure, chest pain, lightheadedness, and extreme fatigue. Now, prior to a transfusion, it's necessary for the client to be type and cross-matched for the transfusion to make sure that they're getting the appropriate kind of blood and to make sure that they're not getting any blood that would have any antibodies that they would likely have a reaction to. So we send off a sample for typing and cross-matching to the lab, to the blood bank. There's a few different types of blood. We have type A, B, AB, and O. And any of those can be Rh positive or Rh negative, such as A negative, A positive. Now the O negative type blood is the people that have O negative blood, they can be universal donors because their blood doesn't contain any of the A, B, or Rh antigens, and they can safely be given to anyone. The people that have AB positive blood are considered to be universal recipients because their blood contains the A, B, and Rh antigens, and they can safely receive any type of blood. In most states, LPNs are not allowed to initiate a blood transfusion. However, they are allowed to monitor the client while they receive a transfusion. Prior to the transfusion of any blood product, it's necessary that we obtain a consent for the blood transfusion from the client or guardian, etc. The blood sample will be drawn and then we send it for the type and cross match. There are policies for administering blood products, and they're going to vary from facility to facility, so you need to be familiar with and follow your institution's policies. Before we even go get the blood from the blood bank, we need to make certain that we have an IV line initiated, and we're going to begin infusing normal saline. Normal saline is the one fluid that will not interact with any of the blood types or the antigens. The blood product unit needs to be checked at the client's bedside by 2 licensed professionals. We're going to check to make sure it's the right client, make sure that it's the right blood type, make sure that it's the right blood bag number, the expiration date has not expired, etc. We need to initiate that blood product within 30 minutes of receiving it at the bedside. And if we're unable to do that, if we cannot get it started within 30 minutes, we have to return that blood to the blood bank. Vital signs are going to be required prior to the administration of the blood product and per facility policy. Now, some physicians are going to require pre-medication prior to transfusion, such as acetaminophen, to help decrease the likelihood or the severity of any reactions. When you're infusing blood, you have to use tubing that has a built-in filter. After the initiation of the blood product, the nurse will stay with the client for at least 5 to 10 minutes after initiation to watch for reactions, and we'll be doing that by taking vital signs and monitoring the client closely, asking questions, etc. If we have to give really, really rapid transfusions, that blood is cold, and we could potentially cause the client to be hypothermic. So we do have blood warmers that are available that we can use to warm up that blood quickly in those types of situations. And we can also use pressure bags to increase the flow rate if we just have to get that blood in quickly. The transfusion of packed red blood cells, we need to understand that we should be using at least a 22 or 20 gauge IV catheter. We can use smaller needles, but it needs to be at least that 20 gauge. 22 is acceptable if that's all we've got. We administer each unit over 2 to 4 hours, and that administration set needs to be changed at least every 4 hours. We infuse the packed red blood cells slowly for the first 15 minutes, watching for the reactions, and then we increase that flow rate slowly. One way to help prevent the risk of infection and reactions with blood transfusions is to collect the client's own blood before a planned procedure, and then we can transfuse that blood back into the client if it's needed. And this is what we call an autologous red blood cell transfusion. The client will donate blood several times prior to the procedure, and then the blood bank will store that blood until it's potentially needed. With platelet transfusions, we infuse platelets when their count falls below 20,000. Platelets are commonly ordered in what we call 4-packs or 6-packs, with each pack containing about 60 mLs. We have to use at least a 24 gauge catheter to infuse those platelets, and we can infuse it as fast as the client can tolerate. With fresh frozen plasma transfusions, plasma has been separated from the whole blood by the centrifuge, and then we freeze it very quickly. And it will contain all of the clotting factors as well as the plasma proteins. Cryoprecipitate contains only fibrinogen and the factor VIII, and it can be further separated out from plasma and administered with just those two factors. And again, with the fresh frozen plasma or the FFPs, we can infuse those as quickly as the client can tolerate, and that will usually be over about a 1 or 2 hour period. Now, with blood product transfusion reactions, there's 4 main types, and some of this information I'm getting from your Med-Surg textbook, but your IV textbook also has some information. It goes into a little bit more detail. For this course, we're just sticking with the 4 main kinds. That will be hemolytic, and with hemolytic, we have an antigen-antibody reaction to the ABO incompatible blood, and that will happen shortly after starting the transfusion. The anaphylactic reaction, we have a type 1 hypersensitivity reaction to plasma proteins, and that happens within 30 minutes of starting the transfusion. With the febrile reaction, the recipient's antibodies react to the donor leukocytes. That will happen within 30 to 90 minutes of starting the transfusion. And then the circulatory overload. The client's cardiovascular system, for some reason, is not able to manage the additional fluid load, and it can happen anytime during the transfusion to even several hours following the end of the transfusion. Symptoms of a reaction are going to include back or chest pain, fever, chills, a decreased blood pressure, urticaria, wheezing, dyspnea, or coughing during the transfusion. So what do we need to do? Well, first of all, stop that transfusion immediately and keep that IV line open with normal saline. Now, there are some transfusions that may not require discontinuing, and that may be febrile or the allergic reactions that are controlled with antihistamines. I'm not saying that you should ever start or stop a transfusion or keep it going without talking to the physician first. That would be the most important thing. Immediately notify that provider, the nursing supervisor, and the blood bank. So if it will be a true reaction, then you're going to remove the blood bag and the tubing, and you're going to save that unused portion of the blood bag for the blood bank. Then be prepared to administer oxygen, epinephrine, solucortef, furosemide, or antipyretics that are prescribed by the provider. Be prepared to collect blood and urine samples from the client for evaluation, and then make certain that you complete the appropriate documentation.